Let's start reading about SLE. Now, rheumatology becomes all the more important if you are preparing for INICET. For NEET PGO exam, of course, rheumatology is important. SLE, rheumatoid arthritis, sarcoid, Beshi. These are some of the topics from which one question is at least there. And you know, and I also know that every question matters in exam, because even one negative marking or one wrong answer can take you thousands of ranks behind. So let's start preparing for this. If you are preparing for INICET, this becomes all the more important because the AIIMS is one of the few hospitals in the country that has a separate rheumatology department. So rheumatology is something that becomes very important in medicine department there. So whenever a question comes up, a question paper comes up, one question from rheumatology is definitely going to be there. So let's start reading about SLE today. Now, if we all know that SLE stands for systemic lupus erythematosus. Now, how are we going to read about it? So, first of all, we'll talk about the antibodies. We'll talk about antibodies. Okay. Secondly, we'll talk about the diagnostic criteria. The diagnostic criteria. Then let's talk about the clinical features. After that, we'll talk about treatment. And then a little about pregnancy and lupus. Very important. So this last part is actually the most important part of the whole chapter. So let's start this. We start with antibodies. I think all of you know, we all know that SLE has one very important, one most common antibody which we all know about is ANA, anti-nuclear antibodies. Right? So let me just decrease this a little bit. Let me choose black. And let's start. So if we talk about antibodies, ANA is one of the most common antibodies in SLE, but it is not the most specific. The most specific one is anti-dsDNA. So if you are asked most common antibody in SLE, that will be ANA. If you are asked most specific, then it will be anti-dsDNA. Most specific. Then drug-induced lupus is also one entity that you should be aware of, and we have antihistone antibodies in that. Drug-induced lupus. Now, what are the drugs that can lead to this? What are the drugs that can lead to this? So the drugs are procainamide, hydralazine, methyl dopa, chloroquine. Chloroquine is an anti-malarial, right? Procainamide is an antiarrhythmic. Hydralazine, methyl dopa are used for hypertension. So these are the drugs that are known to cause SLE. Now, if we talk about the other antibodies, for example, APLA. So APLA antibodies lead to APLA syndrome, or now we call it antiphospholipid syndrome. So for APS, so 50% antibodies in SLE, 50%, around 40 to 50% patients have these antibodies too. They may or may not fit the diagnostic criteria of antiphospholipid syndrome, but the antibodies are there. Now, secondly, CNS lupus also becomes important. So anti-neuronal or anti-glutamate antibodies are also very specific for CNS lupus. So if you are suspecting CNS lupus, these are the antibodies that you need to test for. So this is very important. These antibodies are very, very important. Now let's talk about what are the diagnostic criteria of SLE. Let's talk about what are the diagnostic criteria of SLE. Let me write down all of these here. So we talked about antibodies, then we talk about the diagnostic criteria, then we talk about clinical features, treatment, pregnancy, and lupus. Right? So we have completed this. We know about the antibodies. There are multiple other antibodies, but these are the ones that we usually talk about. One important thing about antibodies will be that these antibodies are tested by immunofluorescence rather than by ELISA. So immunofluorescence becomes important. This is also asked in a question that what is the method that you will use to test the antibodies in SLE, and the answer will be immunofluorescence method. Now, if we talk about the diagnostic criteria, we had something known as a SLIC criteria in 2012. Now, the sensitivity and specificity, so it had a good sensitivity, 97%, but the specificity was low, 84%. Right, but then we came up with EULAR ACR criteria. So EULAR ACR 2019. So this is American College of Rheumatology and the European League Against Rheumatism 2019 criteria. Now this criteria increase the specificity of diagnosis, which is very, very important in a patient like SLE, because we have to start them on something like an immunosuppressant. It takes a toll on the patient. So you can't be wrong with the diagnosis. You can't miss out on a diagnosis, right? So 96% of sensitivity and 93% of specificity. Now, if we talk about what exactly happened in SLIC criteria, how do we diagnose SLIC criteria? We'll talk about the EULAR ACR criteria also. But if you are asked which one is, followed these days for diagnosis of SLE, your answer should be EULAR ACR criteria. So that is one. One second, guys. Right. So let's start with the EULAR ACR criteria. Let me take out a photograph for that. SLIC criteria and the EULAR criteria. Let's add both of those. Let's first read about the SLIC criteria. So as you can see, we have already talked about that the SLIC criteria was given in 2012. Now for diagnosing SLE by SLIC criteria, we should have total of 4 features with at least one clinical feature and one immunological feature. So it is divided into clinical features and immunological features. Clinical features are basically our clinical findings, and immunologic features are antibodies. Or it should be a biopsy proven lupus nephritis with either of anti-dsDNA or ANA antibodies. So 4 features: one should be a clinical criteria, one should be an immunological criteria, or a kidney biopsy proven lupus nephritis along with either anti-dsDNA antibodies or ANA antibodies. So what are the clinical features? The clinical features are acute cutaneous lupus, maculopapular lupus. Now, malar rash is a butterfly rash around the cheeks, and it spares the nasolabial fold. It doesn't involve the nasolabial fold. Chronic cutaneous lupus is DLE, discoid lupus erythematosus. These are lesions which also have carpet tax sign, because this is the look that they have because of the scales. Like in a carpet, there are multiple small threads coming out of the carpet. Similarly, if there are scales on the lesion and it has been there for a chronic period of duration, then that is known as a carpet tax sign. And because it gives it a look of carpet, that's how DLE looks like. And of course, the rash is discoid in shape. Then there are oral or nasal ulcers, non-scarring alopecia. So if you start from head to toe, you have 3 till face alopecia, non-scarring alopecia, oral or nasal ulcers, acute cutaneous, chronic cutaneous lupus. 4 तो यही हो गए. Then synovitis in more than or equal to 2 joints. Synovitis in more than or equal to 2 joints. Serositis, renal neurologic hemolytic anemia, leukopenia, thrombocytopenia. EULAR criteria combined all these 3 hematological features. In a CBC report, you have an HB, you have WBC count, and you have platelets. So all 3 of these. So hemolytic anemia, leukopenia or lymphopenia, and thrombocytopenia. Among immunological features, ANA positivity or anti-dsDNA positivity, anti-Smith, antiphospholipid, low complement, and DCT positive. DCT positive. DCT positive tells you about, indirectly tells you about hemolytic anemia. So out of these clinical and immunological features, if there are 4 features, for example, if a patient has malar rash along with a positive ANA more than 1:80 concentration by immunofluorescence method, then we can, by SLIC criteria, that patient becomes a patient of SLE. But this is not very specific, right? But this is highly sensitive. It doesn't miss out on a diagnosis. But it can give a false positive diagnosis to some patients. So that's where the specificity comes in. Specificity is all about false negatives. Sensitivity is also all about true positive, right? So this is how SLIC criteria goes. Now let's see what is the difference in the Euler ACR criteria. Let's check out the Euler ACR criteria. The Euler ACR criteria, now I have made a mnemonic for this because now this criteria becomes really important. So our mnemonic is FSH not in men. FSH not in men. Right, so they have given points. They have given points to clinical criteria and immunologic criteria. To fulfill this criteria, this is actually a classification criteria, but to fulfill this criteria, patient should have an entry criterion. Now, the entry criterion is ANA more than or equal to 1:80. 1:80 by immunofluorescence. More than or equal to 1:80 by immunofluorescence. Plus, if the patient is having ANA positivity, then only you go ahead with the additive criteria. Now, the additive criteria are given certain pointers. The additive criteria are clinical features as well as antibodies, and they have certain points. Now, if they add up, if the points add up to 10, and the patient is having ANA positive more than or equal to 1:80 by immunofluorescence method, the patient becomes an SLE patient. Patient is classified as a definite SLE. Right? If there are few features, less than 10 features, and antibodies ANA more than or equal to 1:80, then the patient becomes a possible SLE patient. So now, what does this mnemonic stand for? FSH not in men. We know that FSH hormone is not used in males. It's a female hormone, so this is easy to remember. F stands for fever. F stands for fever. S stands for serosal. So serositis. So serosal. Serosa is the layer around the lungs, like pleura, pericardium, peritoneum. So sorry, these are the serosal layers. So serositis. H stands for hematologic domain. Hematologic means leukopenia, thrombocytopenia, and autoimmune hemolysis. So if I try to be more specific for this, leukopenia and autoimmune hemolytic anemia. Now, autoimmune hemolytic anemia can also be interpreted as positive if the DCT is positive, because that also tells us about hemolytic anemia and thrombocytopenia. Then what does N stand for? N stands for the neurodomain. In neurology, patients can have delirium, confusion, psychosis, seizures. Right? And then we have M. M stands for musculoskeletal. Musculoskeletal. M stands for musculoskeletal. Musculoskeletal. So synovitis more than or equal to 2 joints. Please remember that. And it also stands for mucocutaneous. M is also there for mucocutaneous. This N stands for neurology, renal domain. Sorry, nephrology, renal domain, nephro. Right? In mucocutaneous, we have recurrent oral ulcers. Now, the oral ulcers, what is the difference between the oral ulcers of SLE and oral ulcers of Behçet? In SLE, the ulcers are painless. And in Behçet, the ulcers are painful. The ulcers are painful. In Behçet, the ulcers are painful. And in SLE, the ulcers are painless. And we know the cutaneous features can be acute, subacute, or chronic. Acute is malar rash. Subacute is again malar rash. Chronic cutaneous SLE, sorry. Chronic cutaneous SLE is DLE, discoid lupus erythematosus, where we have discoid lesions. We can have a carpet tag sign too. So this is all about the clinical domains of the ULAR ACR 2019 criteria. If we talk about the immunologic domains, now there are 2 points given to antiphospholipid antibodies. Antiphospholipid antibodies. Then low complement. So low C3 or low C4, 3 points, and low C4, 4 points. And then there are anti-dsDNA and anti-Smith antibodies. So either antiphospholipid antibodies or anti-dsDNA antibodies or anti-Smith antibodies or a low complement level in C3 or C4 or C3 and C4 makes it more likely for the patient to have SLE. So this is all about the ULAR ACR criteria. You can take a screenshot of this. Then let's move on. Please remember the mnemonic FSH not in men. Remember the mnemonic FSH not in men, and you can also apply this to the SLIC criteria. You can apply this mnemonic to SLIC criteria. Do that by yourself and let me know whether you were able to do it or not. Going back. Yes. So, all right. So this was all about this. Now let's talk about the clinical features in a little bit more detail. So antibody is done. Diagnostic criteria is done. Antibody is done. Diagnostic criteria is done. Moving on to the clinical features. So moving on to the clinical features. Now, in this diagram, they have beautifully depicted all the all the organs that are clinically involved in lupus. In my notes, I have made these diagrams by myself. So you can also go through the notes. I think going through the lectures along with the notes is going to be very useful, because that is how I processed the chapters while reading, and that is how I teach too. So that is going to help you. And try to have a printout of the notes when you are having these lectures or when you are listening to these lectures. That is going to be really helpful. Now, if we talk about SLE, we start with the neurologic features. So if we start from head to toe, we have brain. In neurologic features, we have cognitive disorders, we have dementia, depression, seizures, stroke, and TIAs. So SLE is also one of the causes of young stroke or TIAs. Coming down to mouth and nose, again, ulcers, low-grade fever. Ocular, in eyes, there can be Sika syndrome, that is dryness of eyes. There can be episcleritis, there can be scleritis. Cutaneous features, see, this is how a butterfly rash involves the SLE patient, the cheek. Now, if you can see how beautifully the nasolabial folds have been spared. Now, this is the difference between malar rash of SLE versus acne rosacea rash. That also looks a little bit similar, but in this, the nasolabial fold is spared, and in acne rosacea, that is involved. And can you see how a discoid lesion is there, and can you see the little scales on this? Gives it a look of a carpet. So this is known as a carpet tack sign. This is a chronic cutaneous finding, a chronic cutaneous lupus, DLE, discoid lupus erythematosus. Right? If we talk about hematology, I wanted to tell you that anemia. So it is a normocytic normochromic anemia in SLE. Leukopenia means WBC count of less than 4,000, or a lymphocyte count of less than 1,500, or a platelet count of less than 1 lakh. So these are the criteria in SLE. Now, as far as joints are involved, what is the difference between a joint involvement in SLE and rheumatoid arthritis, the involvement is that in SLE there are no erosions, so it is a non-erosive arthritis. In rheumatoid arthritis there are erosions. There are erosions. So a non-erosive arthritis, non-erosive arthritis is a feature of SLE. We'll talk about lupus nephritis in quite detail, because lupus nephritis is the most common cause of death in SLE patients. This renal, it is the most serious, and it is the most common cause of death in SLE patient, lupus nephritis. So we need to talk about this in little bit of detail. But from here, if we start from head to toe, let me revise this for you. If we start from head to toe, please revise with me. Alopecia, take your eyes off the screen and you should remember this right now, right here. बाद के लिए नहीं छोड़ना है, अभी याद कर लो. So alopecia, it will be a non-scarring alopecia. Then there is CNS features, which include seizures, psychosis, depression, young stroke, young TIAs. Then we come to eyes. Coming down to eyes, there can be Sicca syndrome, that is dryness of eyes. There can be episcleritis or scleritis. There can be cotton wool spots on the retina. Then coming down to the skin. So butterfly rash, mala rash, sparing the nasolabial fold, which is the difference between a rash of SLE and a facial rash of acne rosacea. Then we talk about the mucosal covering. So oral ulcers. So oral ulcers in SLE are going to be painless, while oral ulcers in Behçet are painful ulcers. Then coming down, so while we are talking about cutaneous, again chronic cutaneous discoid lupus, carpet act sign, remember that. When we are coming down to the joints, then at least 2 joints should be there. There should be a synovitis, so there should be a joint inflammation. Inflammation is seen as pain and swelling in the joints. And the erosions, the arthritis in SLE is a non-erosive arthritis as compared to rheumatoid arthritis, which is an erosive one. So you look at erosions in the X-ray, in the joint X-ray. You find erosions, this is not SLE. You do not find erosions, you have other features, this can be SLE. Then if we talk about organs in serositis, so serosal surfaces, so pleuritis can be there. If we talk about heart has only 3 layers. There is a pericardium, there is an endocardium, there is an epicardium, right? So, and there is a myocardium. So, myocardium involvement leads to myocardial infarction. So, SLE is also one of the causes of young MI. Pericarditis is the most common cardiac manifestation of SLE, where there can be a pericardial effusion also, or there can simply be a pericardial inflammation leading to pain. The serosal surfaces are painful structures in the body. So, a chest pain. So, it can be an atypical chest pain. Then we talk about the patients can present with chest pain. Then endocardium involvement. So there can be a Liebman sac endocarditis, something known as a Liebman sac endocarditis. So if we talk about heart, there can be young MI, there can be a Liebman sac endocarditis, and pericarditis is anyways the most common feature of SLE, right? Now, if we come down to kidneys, lupus nephritis, we'll talk about the stages in detail. If we talk about the peritoneum, then again, splenomegaly, peritoneal effusion, inflammation, peritonitis, there can be ascites also. Then there can be pedal edema. If we talk about hematologic features, then hematology includes hemoglobin, so normocytic normochromic anemia, WBCs, so TLC count less than 4,000, or lymphopenia, lymphocyte count, absolute lymphocyte count less than 1,500, or platelets, thrombocytopenia less than 1 lakh, right? So these are the basic clinical features of SLE head to toe. I think you should remember it from now onwards. There should not be a problem. Now let's talk about lupus nephritis. Take a break of 2 minutes. Let's talk about lupus nephritis. Okay. Break over. So clinical features done. We are only left with lupus nephritis. Let's talk about that. Mhm. Yes. So here we go. So beta, lupus nephritis. Take a sip of water. I will have a sip of coffee. Don't drink more than 1 mug of coffee in a day. Not helpful. Do not rely on coffee for your memory. Again, not helpful. You can rely on revisions. So lupus nephritis, most serious features of SLE, most common cause of death in SLE. If it remains untreated, it leads to an end stage renal disease within 2 years, and then it leads to, of course, it increases the mortality. So whenever you diagnose a patient of SLE, this is a tip for all the MD residents out there, or all the people who are going to take MD medicine. If there is a patient in which you are suspecting SLE, please screen the patient for lupus nephritis. If you find the initial stages, get a biopsy done, stage it, because the treatment differs with the stage of lupus nephritis, and treat the patient aggressively, because the patient is not going to give you much time, right? So you have to go aggressive on immunosuppression if the patient has features of lupus nephritis. And it can be asymptomatic, so you need to screen for it. It's you who will be diagnosing it. The patient is not going to come to you with proteinuria, with a history of proteinuria. You have to find that. So always screen a patient of SLE for kidney involvement. Okay. So if you can see here, lupus nephritis is divided into 6 stages. Class 1 is minimal mesangial lupus nephritis, where light microscopy doesn't show anything, but immunofluorescence shows minimal mesangial immune deposits. Class 2 is mesangial proliferative. Now you can see the proliferation in the mesangium by light microscopy itself. Then we have class 3, which is focal lupus nephritis. Now by focal we mean less than 50% of all glomeruli. Whereas class 4, which is diffuse, it means more than 50% of all glomeruli are involved. Class 5 is membranous lupus nephritis. Class 6 is where more than 90% of glomeruli have sclerosed. So very easy to remember: minimal mesangial, mesangial proliferative, focal lupus nephritis, diffuse lupus nephritis, membranous lupus nephritis, and advanced sclerotic. So minimal mesangial, you can't see anything on light microscopy, but on immunofluorescence, you find immune deposits in the mesangium. Mesangial proliferative, you find immune deposits or the proliferation of mesangium on light microscopy. Focal, less than or equal to 50% glomeruli involved. Diffuse, more than or equal to 50% of glomeruli involved. Membranous is membranous, so somewhere in between diffuse and advanced sclerotic. Advanced sclerotic is now the patient has reached ESRD. In fact, the patient has reached ESRD when you when you find that the patient has class 5 lupus nephritis. Class 6, more than or equal to 90% are sclerosed. Advanced sclerotic lupus nephritis, the name itself suggests that the disease has advanced to a stage where it has sclerosed most of the kidney. This most of the kidney is 90% of the kidney. Okay, so this is important. Now let's move on to the treatment quickly. Moving on to the treatment part. Now, when we talk about treatment, first thing is that SLE patient criteria fulfilled or not. If the criteria is fulfilled, but the patient is not in flare, quality of life is acceptable, then you can put the patient on NSAIDs Right. You can put the patient on NSAIDs or HCQ or methotrexate. These are the long-term steroid-sparing agents. If the patient is in flare, the quality of life is unacceptable, then you please start the patient on IV steroids. So a steroid pulse is must, followed by oral steroids and a steroid sparing agent. All steroid sparing agents take at least 6 to 8 weeks to come into action. So for that 6 to 8 weeks, you need to put the patient or keep the patient on steroids, oral steroids, right? So when we say IV steroid pulse, we mean methylprednisolone 1 gram IV once a day for 5 days, 3 to 5 days, right? So IV steroid, when we say IV steroid, we mean IV methylprednisolone 1 gram OD once a day for 3 to 5 days IV. This is pulse. This is steroid pulse. Then it is after resolution, we put the patient on either MMF or azathioprine for maintenance. So this was induction, then we did maintenance. By maintenance, we mean that we are maintaining the levels of antibodies. So we reduce the antibodies to a significant level by giving IV pulse. Now we are going to maintain that reduced antibody level, right? So for maintenance, if refractory to this, if there is no response to MMF or azathioprine and the patient keeps on relapsing on this also, then we have options like rituximab, belimumab, tacrolimus. Then we have these options. First, we try to put the patient on MMF or azathioprine, and lupus nephritis, cyclophosphamide becomes important for lupus nephritis. Cyclophosphamide affects fertility of the patient. So it also, two common adverse effects of cyclophosphamide are, one is fertility issues in young patients, so we refrain from giving it to young patients, and second is hemorrhagic cystitis. That can also be asked in exam. It was asked 10 years ago. It can be asked again. Let's talk about some of the medications that we use in SLE. What are the adverse effects and what are the doses? Let's talk about that. And then we'll talk about pregnancy and lupus. So, treatment of SLE. HCQ. So HCQ is used as 200 milligram once a day or 200 twice a day. Usual dose that we start with is 200 once a day, and we can go up to 200 milligram twice a day depending on the patient's response. This can lead to retinal toxicity. It can lead to a severe dermatitis. It can also lead to yellowish discoloration of the skin. So retina and skin. What does HCQ affect? Adversely, retina and skin. Second, methotrexate. So methotrexate, the dose we start with is 10 milligram once a week. We can go up to 25 milligram once a week. With methotrexate, the problem is that it reduces folic acid. In the body. It also leads to bone marrow suppression. Right, so it can lead to bone marrow suppression and hence anemia, leukopenia, pancytopenia. It can also lead to pulmonary fibrosis. It can also lead to liver toxicity. And methotrexate is also known to cause pseudolymphomas, where it can lead to enlargement of lymph nodes, and it is not a malignant growth, it is an inflammatory growth, non-inflammatory growth because of the medicines. So methotrexate is also known to cause pseudolymphomas. The third is cyclophosphamide. The dose of cyclophosphamide that we use is 500 milligram IV once a fortnight, that is once in 2 weeks, or you can give 1000 milligram IV once in a month, monthly, for 6 months. For 6 months. This is for induction. This is for induction. Toxicity is with the fertility. So it can lead to infertility. It can lead to hemorrhagic cystitis. To prevent hemorrhagic cystitis, we usually put the patient on Mesna. So we also infuse Mesna IV along with cyclophosphamide. Whenever we call the patient for cyclophosphamide induction, along with cyclophosphamide, we also give Mesna. And practically speaking, we divide Mesna as, so if we take 1000 milligram, we give 500 milligram Mesna, then we give 1 gram of cyclophosphamide, and then we give the rest of the 500 milligram. That is one way to give. Every hospital or medical college has their own protocol. This is what we follow at AIIMS. Moving on to MMF. Mycophenolate mofetil. Mycophenolate mofetil. Okay, this is supposed to be an I. So mycophenolate mofetil, the dose that we start with is 500 milligram twice a day, and we can go up to 3 grams in a day. We can go up to 3 grams. So we can go up to 1.5 gram twice a day. And what are the effects or the adverse effects? So it can lead to bone marrow suppression again, and immunosuppression. These are all immunosuppressants. Then if we talk about azathioprine. Now azathioprine is a very cheap drug, so very important for Indian patients because there are patients from Bihar, there are poor patients whom cannot afford to have rituximab induction or cyclophosphamide or MMF. MMF is also costly. Azathioprine is cheap, so azathioprine becomes important here for us. So azathioprine, we start with the dose 25 milligram once a day, and the maximum dose that we can go up to is 3 milligram per kg per day for induction and 1 milligram per kg per day for maintenance. So if for a normal 50 kg individual, we can go up to 150 milligram if we are giving induction. We can go up to 50 milligram in a day if we are talking about maintenance. Again, immunosuppression and cytopenias, and also liver. It affects liver, it affects the blood cells. So take a screenshot because I have to erase this now, right? And we'll talk about the rest of the three. If patient is refractory to these, if the patient has relapsed on these or is progressing on these medications, then we move on to medications like belimumab. Now, if we talk about belimumab, the dose is 10 milligram per kg IV, week 0 to 4, and then monthly, once in a month. So today, then 2 weeks later, then 2 weeks later, and then monthly, once in a month. Or it can also be given as 200 milligram subcutaneous once in a week for around 6 months. Rituximab is a wonder drug. Not exactly a wonder drug, but rituximab immediately brings down the CD2019 levels, the antibody levels, to almost zero. Right? So rituximab, 1 gram IV, week 0, and then 2 weeks later. So week 2, right? So 14 days gap. 14 days gap, we can give 2 rituximabs, 1 gram, 2 doses, day 0 and day 14. Day 0 and day 14. Right? Or this another dose is 375 milligram per meter square per week for 4 doses. So for 4 weeks. So either of these two. Rituximab again affects the blood levels, so hematological adverse effects. It also affects the liver. It also leads to significant immunosuppression, right? And then the last one is tacrolimus. Now, tacrolimus is something we give to the to transplant patients in order to avoid graft rejection. But here we can use it if the SLE is refractory and progressing despite all the other measures. It is an oral medication, 2 milligram twice a day. It acts on mTOR pathway. 2 milligram twice a day. Remember that the trough level should not exceed 5.5 nanogram per ml. This is the value that is usually asked. What should be the limit for the trough level for tacrolimus? So that the answer is 5.5 nanogram per ml. Right. So now moving on to pregnancy and lupus. So remember belimumab, rituximab, and tacrolimus. Remember this for refractory SLE. For refractory SLE. Okay. So if we talk about pregnancy and lupus, this is very, very important. Students, focus. Pregnancy and lupus. So one question that comes to everybody's mind is, if the patient is pregnant and having features of SLE, what do you do? What are the medications that you can give? So let's talk about all the medicines of SLE. Number one, steroids. Now, steroids are something that are FDA category A, which means they are not teratogenic, especially in second and third trimester, right? So placental, what happens is placental enzyme, there is an enzyme in the placenta which is 11 beta dehydrogenase. Now, when placenta releases this enzyme, it inactivates glucocorticoids. So, the glucocorticoids do not harm the fetus because they do not reach the fetus. But it cannot deactivate dexamethasone. So we try to remember that. So steroids can be given if the patient is having an SLE flare and patient is present. We can give her IV steroid pulse because the benefit outweighs the risk. We do not want the patient to develop lupus nephritis and increase her risk of mortality 2 years or 3 years down the line just because she was pregnant when she had SLE. We always have to weigh the benefit versus risk. So we give the patient IV steroid pulse. Secondly, if we talk about cyclosporin, tacrolimus, and rituximab, these are all category C. By category C, we mean that teratogenic in animals, but enough human studies are not there. Teratogenic in animals, no good evidence in humans. That is category C, evidence in humans. So if there is a refractory SLE patient in flare and you have to do induction, you have to decrease those antibody levels because the process is rapidly progressing, you can give the patient rituximab. Third, azathioprine, HCQs, MMF, cyclophosphamide, these are all category D. And by category D, we mean that these cannot be given in a pregnant patient no matter what. So you can do a pulse with steroid, you can maintain the patient on low dose of oral steroid, or if the patient is refractory to that, you can give a rituximab. But no azathioprine, HCQ, MMF, and cyclophosphamide. So category D means teratogenic, found enough evidence to say that these are teratogenic in humans. And then, my dear friends, methotrexate is category X. अब ये तो नाम से पता चल रहा है, X is a complete no. Don't even think about giving methotrexate to a pregnant patient ever. Okay, so steroid is something that you can give. Rituximab is something you can give. Rest all is a complete no. So please remember this about pregnancy and lupus, right? Now we are almost done with this. Let us talk about some of the previously asked questions, previous year questions, and I can give you a test right here. So you can, sorry, so you can judge how much you have retained and learned in this lecture. So let me give you certain questions. You can write the answers. Please be fast. Do not waste time. Be fast. So PYQs on SLE, right? So let me ask you the questions. Students, are you ready? Take a sip of water and be ready. Antibodies in drug-induced lupus. Please write the answer. Antibody in CNS lupus. Drugs causing lupus. Keep writing your answers. You don't have to write the question. You can just take a screenshot later, but keep writing your answers. 1, 2, 3, 4, right? Keep writing your answers. Markers in urine in SLE. What is lupus? Difference between arthritis of SLE versus RA. Difference between oral ulcers of SLE versus Bichet. Difference between the rash of SLE versus acne rosacea. Systemic hypertension is a feature of SLE. Yes or no? Right or wrong? Is this statement right or wrong? Just write right or wrong. Wire loop lesions in SLE. Okay. Drugs that can be used for induction in a pregnant patient of SLE. And I'm not talking about induction of labor here, guys. I'm talking about induction in the sense to decrease the immunity, to decrease the autoantibodies in an SLE patient. Criterias for SLE. And what else can I ask you? Okay, 2 more questions. Yes, markers of SLE flare. Markers of SLE flare. Please write down. I haven't told you about this, but I want you to answer this for me. Most serious clinical feature of SLE. And one last question. Most common cardiac feature. Most common cardiac feature of SLE. Have you written the answers? Can we now discuss the answers, please? So antibody in drug-induced lupus, antihistone antibodies. Please give yourself 1 mark for each correct answer and -1 for each wrong answer. So antihistone antibodies. Antibodies in CNS lupus, anti-glutamate receptor or anti-neuronal antibodies. Anti-neuronal antibodies. Drugs causing lupus. So procainamide, hydralazine, methyl dopa, propyl thiouracil, sulfasalazine, Lithium. Sorry, markers in urine for SLE. Markers in urine. So the urine markers are hepcidin, endothelin 1. Then there is lipocalcin 2. Lipocalcin 2, and then there is a urine MCP1 marker. What is rupus? Rupus is rheumatoid arthritis plus SLE. Now, arthritis in SLE is a non-erosive arthritis, and rheumatoid arthritis is an erosive arthritis. Oral ulcers in SLE are painless, while in Behçet they are painful. Rash in SLE spares the nasolabial fold, while acne rosacea involves the nasolabial fold. Systemic hypertension is not a feature of SLE. Wire loop lesions are seen in lupus nephritis. Drugs that can be used for induction in pregnant SLE patients, steroids, and if refractory, then rituximab. Criteria for SLE, we have SLIC criteria 2012, and we have EULAR ACR criteria 2019. Markers of SLE flare. Good question. Markers of SLE flare. ANA is not a marker. Anti-DS DNA is one of the markers. C3, C4 complement levels are the marker. Anti-C1q antibody. Anti-C1q antibody is also a marker of flare. Then there is a serum B lymphocyte, B lymphocyte stimulator levels.